This is a talk I put together this last 6 months or so, and it reflects some work that was done with one of my prior medical students who now is faculty at Brown in spine surgery, Alan Daniels, and some other work as well. But really, a lot of it is opinion. It's not necessarily all data-based. Is there? How do I? Is it this? Okay. All right. So these are my conflicts. None of them really relate much to this topic. I do serve as an examiner for the American Board of Orthopedic Surgery, and I've worked as a program director both for an orthopedic residency at OHSU as well as their fellowship there, and participate as a faculty in the fellowship here at Swedish Neurosciences Institute. So I want to start with this. It's a little bit about collaboration, right? So if you as an orthopedic surgeon want to start talking about creating combined training programs that are going to include neurosurgery, I think we best acknowledge that there's we want to start as colleagues, right? And I would say if neurosurgeons took the same approach, we'd want to say the same thing. But at any rate, I have always liked neurosurgeons, most of them. And in fact, some of my best friends are neurosurgeons, and that is definitely true. And I wanted to also start with this slide. So I've been doing a master's program at Dartmouth in healthcare delivery science the last 18 months. And that included a negotiations class, and this slide is from that. And what I thought was very interesting about this slide is this was a sort of a model negotiation that was set up, kind of role-playing negotiation. We all broke into a number of small groups, and it was intentionally meant to be contentious. So it was set up so that both parties felt aggrieved. Both parties felt that the person or the other party they were negotiating with had been unfaithful or dissembling, and both parties were told that they should not accept less than what the other party was willing to, or would not accept the offer, the greatest offer that the other party was willing to give. So both parties were going to be aggrieved in this negotiation. And what this maps is how that played out and how emotions rose from both sides. And I think what you see is that several groups actually kept their emotions in check. They're down here at 1-1, and those groups actually came to an agreement despite the adverse setup. But as emotions rose on one party, that's on the x-axis is one party, and the y-axis is the opposing party, you can see that it's a very linear relationship, and it's pretty much 1 for 1. So whoever goes first immediately gets met in a negotiation with the same kind of level of emotion and anger. So I'm going to try to stay down at a level of 1, and I don't think tonight there's going to be any issue. But if actually this stuff ever comes to pass and there's truly negotiation between ortho and neuro to try to create a combined spine pathway, there's going to have to be negotiations from both sides. So I'll start with that. So where are we in 2017? I'm going to be critiquing orthopedic surgery spine training. So I'm going to argue that current orthopedic spine surgery training is not wholly effective. I don't think it's wholly ineffective, but it's not wholly effective. It's not as good as I think it can be. I think we have to acknowledge that there are substantial differences between orthopedics and neurosurgery in terms of the training pathways, and I'm going to argue that I don't think either group actually has all of the answers, but really the two pathways can't both be optimal, so they are very different, and presumably there is some common pathway that might be better than either one currently. I'm going to present some data that does show that orthopedic residents are voting with their feet. So orthopedic residents are working, if they want to go into spine, it's clear, I'll show the data that if they decide to go into spine, they do more spine cases as residents. If they decide to go into total joints, they do more total joints cases. If they decide to go into sports medicine or hand, they do more of those cases. And yet we as orthopedic educators are not creating pathways that make that easy to recognize that is what our residents want to do. And then I'm going to present just some information on historical approaches within general surgery, because general surgery has continued to embrace subspecialization, and I think they have been affected by it earlier in their history than we have, and they've come to terms with it, and they have allowed subspecialties such as vascular surgery, plastic surgery, and cardiac surgery to develop independent pathways for training that do not require completion of a general surgery residency. And I think that's a model that orthopedics and maybe neurosurgery needs to look at. So the argument that current orthopedic training is not as effective as we'd like, I'm going to base it on two issues. One is how our graduates from orthopedic residency that decide to go into spine surgery do on the board exams, which is the lowest passing rate of any of the subspecialties within orthopedics. So why that is, I don't know, but that's a fact and has been for a number of years. And then the second is that we continue to have practice patterns within our community of spine surgery that show high degrees of variability and perhaps among the highest of surgical subspecialties. And I think that may reflect the nature of our business, which is somewhat in the eye of the beholder and is somewhat, we don't have completely a body of evidence to base decision-making on, but I'm going to argue that it may also be due to training issues. So this is an article that came out a number of years ago. Harry Herkowitz was very passionate about this topic, and actually the last conversation I had with Harry, those of you who know him know that he's passed away several years ago, was about this topic, and he was still very interested in and was committed in working on it at that time. But this was data from the ABOS that shows that spine surgery candidates fail at a significantly higher rate than any of the other subspecialty candidates. And again, that's not a blip. That's not a one-time issue. It has been continual. The ABOS tracks the examiner's sort of toughness and calibrates their passage rate, calibrates their scores that the examiners give to an individual examiner's rate of and ratings of candidates. So in other words, it gets normalized. So having a really hard examiner doesn't affect your chances of passing the board exam. And so it's not because spine surgeons are particularly painful examiners, it's because of the candidates themselves and how they're seen. Is it because poor candidates go into spine surgery? I'd like to think that's not the case. I think some of my mentors in my case might have argued, yeah, that you should try spine, that'll work for you. Or is it because we teach them poorly? I don't know. I don't know the answer, but this is a fact. Our candidates do the worst of all of the in training, or all of the orthopedic candidates for the boards. Now, this is a diagram that is meant to illustrate the balance between uniformity of practice and quality of the database. So our clinical database for spine, I actually think is pretty darn good, right? Sport trial within the last 10 years, we've got pretty good documentation of, in my opinion, the need for fusion in spondylolisthesis in at least some cases, the lack of need for fusion in cases without instability, and of course for discectomy. And we have pretty good evidence regarding discogenic back pain, and I think that has become absorbed into our practice now, that while surgery does help some patients with discogenic back pain, many patients will do as well with conservative care, and I think there's been some movement away from fusions for discogenic back pain or total disc replacement. But the data set does remain incomplete, and I do think we're more now on the right, which the green arrow, the database showing improved quality of data, and the diminished red arrow indicating that greater uniformity of practice may be developing. However, we continue to struggle, I think, with a great deal of variability. And this is a slide also from the Dartmouth Atlas. It's called a turnip plot that shows the level of variability per capita using Medicare data in terms of lumbar fusion. And you can see it varies almost tenfold between the low rate within the Bronx and Miami, Florida, and the highest rate actually just south of here in Tacoma and Mason City, Iowa. You know, I know some of the spine surgeons in Mason City, Iowa. Actually, I was born about an hour west of Mason City, Iowa, and graduated from high school about a half hour east of Mason City, Iowa, and my brother lives in Mason City, Iowa, so I know the community of Mason City. That was River City, actually, by the way, in The Music Man. That was, so everybody here actually knows Mason City, Iowa. I don't know why they have so many, so high a rate, although I will tell you it's a small town and they have several spine surgeons there, so I think perhaps that's the reason. So how do we account for that? I mean, I think these are the kinds of things we're going to have to increasingly explain, and really I think this does relate to spine training. I mean, it does relate to the quality of training, and I think the uniformity of training and maybe the lack of a common body of knowledge that we try to communicate. And that's you know, the mission of the ACGME is to standardize and you know, make more uniform our training programs in every surgical specialty and every medical specialty. And yet while we do have ACGME credentialing for spine fellowships, if we want to take that pathway, the great majority within orthopedics fellowships do not seek ACGME credentialing and therefore are not subject to any requirement in terms of content. And the end result of that, I think, is variability, and that may be reflected in the variability in practice once our residents get out. Of course, this doesn't tell us what is the right rate. I mean, how many are we doing too much in Mason City and too few surgeries in Miami? Maybe, we don't know. This doesn't reflect that. But I will argue that not all of these approaches can be right. It can't be right to have 10 times the rate in one community versus another. That just doesn't make sense. So a further aspect of spine surgical practice in the community is that it has been subject to relatively rapid change, and again, I think maybe without a sufficient data basis. And this is data on the rates per capita of laminectomy over the 10-year period from 2001 to 2011, mapped against the rates of spine fusion, lumbar fusion, and you can see lumbar fusion went from about 30 to almost 60, so nearly doubled, while the rates of laminectomy went from slightly over 100 to around 50 or half. So that means we're fusing a lot more people, and we're not fusing, or we're not avoiding fusion in a similar number. And I would argue again, what is the basis for this? Is this because I would argue that it's not because great data came out in this time frame supporting use of fusion. I think it may have been increases in or improvements in fusion technology and availability, implants, but I would argue there might also be an economic issue here. And of course that affects not only surgeon decision making, but also it's well compensated to our hospitals. And we all know that. I think we as spine surgeons have to own this data. This is the data. So to move on, to make the point that orthopedic and neurosurgery training pathways do indeed differ. So this is a graph out of one of the papers that Alan Daniels and I worked on, and the red lines that represent the neurosurgical training pathways. The darker line represents orthopedics, and you can see here that the number of spine procedures done as measured out of ACGME case logs for neurosurgical residents runs around 400, somewhere between 350 to 400 by the time they finish their residencies. On the other hand, orthopedic residents register about 100 to slightly less than 200, and it is increasing slightly, but a fairly low slope. And there are some differences by diagnosis. Orthopedic still, as of this time, orthopedic residents still did document doing higher numbers of spinal deformity cases, but we're still talking about relatively small numbers. So most orthopedic residents logged approximately 9 to 10 cases that involve spinal deformity. Neurosurgery logged about 2. Again, I would guess that most of those from most of our residents are going to be in the pediatric realm, not in adult deformity, but clearly striking differences in terms of the numbers of cases performed during training in residency by the two specialties. And this is just another way of looking at that same data, and it shows you as a graph rather than the prior data comparison. But on the left, this is spinal decompression procedures. Obviously, the neurosurgical residents get a great deal of exposure to this with a number of 200 laminectomy procedures for orthopedics. Orthopedists are around 40 by the time they graduate. On the right, again, is the spinal deformity arthrodesis, where we do get a slightly bigger bump as compared to neurosurgery, but again, fairly small numbers in both specialties. So what is the best pathway? Again, the differences here don't equate to quality, I don't think. We don't really know what the differences mean. Case numbers are not the only metric for how we're trained and what our quality of training is, but they are a metric, right? I mean, there's a reason we track case numbers. It's important. Exposure to cases and numbers does matter. So it's not the only metric, but it's certainly one metric. And we need to measure ourselves, comparing ourselves to each other as we move forward, thinking about what might be the best way to train our residents. So this is a second paper, and this was a questionnaire-based study asking orthopedic and neurosurgical educators what their opinions were about the state of spine surgery training nationally. And so on the right were the neurosurgical residency directors' answers, and on the left are the, it's either, and I'm sorry I don't have it labeled, it's either the orthopedic residency directors or the orthopedic spine fellowship directors' opinions. And I'll read you the questions because I know they're small, but there's 4 questions listed here. So one is, do you recommend your trainees complete a fellowship if they wish to do community spine surgery in their practice? 88% of orthopedic directors said yes, they need to do a fellowship. 0 of the neurosurgical residency directors said they need to do a fellowship. So the perception and the intent is that you graduate neurosurgical residency ready to do at least community type cases, and I think that we use that label. I think that means to leave out complex spine, let's say. The next question is, do you recommend your trainees complete a fellowship if they wish to do deformity spine surgery in their practice? Again, for orthopedics, it's almost 100%, 98%, but a high percentage of the neurosurgical residency directors also recommend doing a fellowship for deformity spine, and we could have labeled that complex spine, I suppose, but deformity is certainly one aspect of complex spine, which was kind of the question of interest here. So 86% neurosurgical residency directors felt that their graduates were not ready to do that independently after residency. The third question is, at the conclusion of your training program, are your residents highly confident in performing spinal instrumentation and decompression with a notion, is that part of community spine surgery? Again, 100% of neurosurgical residency directors said yes, they are completely competent. It's about 40% of orthopedic residency directors felt their graduates were ready. And finally, at the conclusion of training program, are they highly confident in performing adult deformity surgery? Very similar to the prior question. 87% of orthopedic residency directors, almost the same number, said they're not ready. The neurosurgical residency directors, actually 70% of them said, yeah, they are ready, even though a higher number wanted their graduates to still go ahead and do a deformity fellowship. And the second part of this study is shown here, and this is, I think, even the most telling. So for me, is even more telling. So in terms of the time spent on spine surgery training, do you think that orthopedic surgery residency training in the United States is too little, just right, too much, or you have no opinion? And now we've added a column which is the fellowship directors, the spine fellowship directors within orthopedics, and that's the middle column. And so the residency directors, 73% think we're getting it just right. Of the orthopedic fellowship directors, 50% say there's not enough spine in residency. And the neurosurgical residencies directors, 71% think that their residents actually get too little spine. Or no, sorry, orthopedic residents get too little spine. And the second one now is about neurosurgical residencies. And orthopedic fellowship directors, 83%, felt that neurosurgical residencies get the volume about right, whereas, and the neurosurgical residency directors, of course, also felt that most of their residencies are just about right. And interesting, the residency directors for orthopedics didn't want to weigh in. So the biggest number here is no opinion. So maybe that's, wanting to stay good friends with their neurosurgical colleagues down the hall. I don't know. But I thought that was an interesting response as well. So again, if we as orthopedic residencies or orthopedic fellowship directors don't believe that our training is optimal, should that be telling us something? I would argue that yes, it should. And I think it probably applies to training outside of spine surgery as well as within the discipline of spine surgery in orthopedics. So what I would argue is that the best training really should utilize aspects of training from both fields. And we tried, this is an opinion paper without really data, or maybe based on some of the data I just presented, arguing that I think it's at least time to think about creating a pathway for spine surgery training that provides more years in training doing exclusively spine surgery, put it that way. And as we thought about, well, what do we learn in orthopedics that we want to be proud of and think we do particularly well, and what can we recognize in neurosurgery that our neurosurgical colleagues probably are learning in a better and more effective way than we do. So for orthopedic surgery, we think we learn bone and particularly bone physiology and bone healing. We learn about growth and development of the musculoskeletal system. We certainly learn biomechanics and material science of implants in depth. We learn about peripheral joint arthrosis, which does affect our evaluations in spine surgery, being able to evaluate a hip or a knee and conclude that this may not, or a shoulder, and conclude that this may not be a spinal issue, but instead a peripheral joint is a critical part of what we learn. And then we do learn a fair bit about scoliosis and spinal deformity, both on the pediatric and to some extent on adult spine rotations. In neurosurgical surgery, I think neurotrauma and the correlations between, let's say, brain trauma and spinal cord injury are certainly, I think, very well taught and probably better than most orthopedic residencies. Intradural process is obviously something as residents in orthopedics we really never encounter, other than to learn that if we discover one, we want to call neurosurgery. Cerebral spinal fluid management is one as well that we need to depend on our neurosurgical colleagues for placement of a lumbar drain, for example, which is an extremely common procedure for neurosurgical residents. Central nervous system tumors, obviously spinal cord tumors in particular, and peripheral nerve tumors. Minimally invasive approaches are one. I don't know completely that really separates, but I certainly think that there's been a greater embrace of those techniques within neurosurgical training than there has been in orthopedics. And I think there's a benefit to seeing spine surgery continually through training. And I've always felt that you learn different things at different stages in your training as a resident. And most orthopedic residents really see spine surgery maybe a couple times, once as a junior resident, once again as a senior resident, whereas neurosurgery residents see it continually through their development, which I think is an advantage, and again argues towards putting more years into the training pathway than we currently get them in orthopedics. And then this is the final bit of data, which is really about current practice of orthopedic residents. And this is based again on case log data, and then pairing that with the subspecialty choice that these graduating residents advertise on their website. These days you're able to most people list their actual fellowship, so you know what fellowship these residents did. And the residents that went into spine surgery averaged 100, and in this, I don't know, I don't know what years this were, but the years these were within their residencies, but 104 cases, as opposed to residents who went into other subspecialties, about 75. For hand surgery, similar similarly reached statistical significance with 240 versus 194. Sports medicine, also statistically significant, 280 sports cases for residents that did that fellowship versus 230 for their cohorts. Total joints didn't quite reach statistical significance, but there still is a difference, 300 versus 260, and same for foot and ankle, 210 versus 195. So again, this is what our residents want as part of their training, is an opportunity to do more of what they see themselves doing when they finish their training. It's something that we're not yet creating opportunities for, and I think this should also be informing our decision making as we begin to think about this. And then finally, here are 3 examples out of general surgery of changes that have been made within the last 2 decades or so that have allowed various training pathways to be shortened and more focused on the goals of the entering residents. So traditionally, vascular surgery did not have its own board, and vascular surgeons were required to do a general surgery residency and then go do a vascular surgery fellowship. So they were performing 7 years of postgraduate training. More recently, there is a vascular surgery board, and there are now vascular surgery training pathways that have shortened that by 1 to 2 years, depending on the program. So it's either 3 years of general surgery followed by 3 years of vascular, again, 1 more year dedicated to vascular, and 1 year less total training. And there are programs that are 5 years of vascular surgery. Similarly, within plastic surgery, and I can remember this when I was a medical student, there really were only 2 programs in the country that allowed graduating medical students to enter a plastic surgery residency. One was at Stanford and the other was at Loma Linda. And those were both extremely popular for obvious reasons, because the traditional pathway was you did 7 to 10 years total with a complete surgical residency, followed by 2 to 3 years of plastic surgery fellowship to become a plastic surgeon. The integrated program has shortened that to 5 to 7 years. And the biggest thing that I think, one of the things I think that should be considered is the benefits to those programs that were willing to take the risk and be innovators here. They had all of the best candidates vying to get into those programs, because who wouldn't want to spend 3 less years in residency? I don't think any of us would argue with that concept. And if you're able to do that, you're going to pick that pathway. So I think I think programs within orthopedics and neurosurgery that begin to look at pathways that allow their graduates to focus on spine earlier are going to have, they're going to draw a benefit of having a candidate class of resident applicants that's going to be quite talented. And finally, there it goes. So similarly, for cardiothoracic surgery, and that program now has been shortened from 7 to 8 years to 6 years with an integrated program that is focused on cardiothoracic surgery from the beginning, or in some cases a 7-year program, not 8, that shortens the general surgery exposure and increases the cardiothoracic exposure. So other fellowships, other subspecialties have chosen to modify their training pathways, and again, I think this is based somewhat historically, because there's been so much subspecialization and peel off of subspecialties out of general surgery that they're maybe more accustomed to it. Whereas within orthopedics and I think probably within neurosurgery, I think it to some extent sounds like heresy still, when you, at least among orthopedic educators, there's a great deal of emotion still about the notion that we split up the house of orthopedics and allow residents to move into subspecialties at an earlier stage. So is that a new paradigm? I would suggest it's at least something we need to consider, and I would suggest that it should be where we want to head as a subspecialty. So I will end with a bit of educational philosophy. So what is the connection point between surgery and chicken sexing? And you could call this chicken gendering, just for clarity, but it actually is called chicken sexing. So I'm not using an inaccurate term. Daniel has heard this, so I apologize to him. But this is an analogy I use in terms of how we teach our our residents and fellows. So chicken sexing is a critical function on a poultry farm, and I grew up in Iowa. I didn't grow up on a farm, but I spent a lot of time on a farm, not a poultry farm. So all of my knowledge of chicken sexing is based on Wikipedia. So please forgive me if I pass something along that some expert in the audience can correct me on, because I may have it wrong. But as I understand it, there's an importance to identify the gender of the new chicks when they are hatched, for two reasons at least. One reason is that there's a different feeding and treatment program. They're separated, and the male chicks are fed and treated differently than the female chicks, and I don't really know the details, just that they're different. The other aspect is that the roosters will, in some cases, kill the male chicks, so they can tell, they know. But it's not obvious to human observers which are the males and which are the females. And it turns out it is not an easy training to master. So the method by which that's accomplished starts with what's called venting the cloaca. So I know that's what it is. So here we have a chicken sexing expert. So you vent the cloaca, and then the genitalia are internal. They're small, and they're somewhat nondescript, I guess. And so the way that you master this skill is you stand shoulder to shoulder with somebody who already knows it, and they will vent the cloaca and identify the gender, and they'll pass the chick to their student and say, this is a male. And these are what you should see there that tells you it's a male. And then they'll do the same for a female chick, and they'll do it over and over and over, and finally the student begins to identify the same characteristics. So the point is, what's the commonality? I'm going to say there's two commonalities. Number one, learning surgery it's experiential learning. You can't substitute being in the OR and learning shoulder to shoulder, and being in the clinic and learning shoulder to shoulder with somebody who knows how to do it with book learning or video learning, or even completely with simulation. All of those things are important, obviously, but you have to learn by doing, and that's why we have residencies. That was recognized generations ago, and it's part of how we train our it's always going to be part of how we train the next generation of physicians. But I think we need to learn to do it well, right, and do it efficiently, right? Because there's increasing cost constraints, and we can't simply continue to make training longer. I'll say there's a second analogy, which actually turns out that chicken sexing, even the most expert chicken sexers, are imperfect at their art. There is a fixed percentage of misidentified chicks, even in the best of hands. So, and I would say I will own, and whatever my skill set is, I will own, I'm not perfect. So I think maybe that's a commonality as well. Usually I get a laugh in here somewhere. Okay, there you go. All right, thank you. No, don't feel obligated. No, don't feel obligated. All right. So what are the potential approaches here? So I would say one of them, it would be to allow greater resident autonomy in picking their pathways and maybe creating a structure for elective rotations. That would be an easy first step, right? I mean, it's a burden for the training programs because we're so used to having a lockstep and always having, I need 2 residents and 1 fellow, or I need this or that for my service to run efficiently. But really, we've increasingly seen service needs of the physician faculty as secondary to the educational needs of our trainees. And I think this is just a next step in that direction. And creating elective rotations might be the easiest way of doing this. This wouldn't require any kind of national change in policy or ACGME credentialing. It could easily be done within the current credentialing paradigm for our residency programs. I would like to see spine subspecialty certification emerge, and if we do that, then I think we'll begin to see a greater percentage of spine fellowships seek credentialing, and ultimately ending, I think, with a board for spine surgery whereby we credential our own trainees, whether they come from orthopedics or neurosurgery. And I would love to see something where I could imagine it within orthopedics, that our graduates maybe do, let's say, 2 or 3 years of orthopedics and then do another 3 or 4 years of dedicated spine training, I think there's no way that we could argue that those graduates are going to be less adept and less capable than our current graduates from orthopedic fellowships in spine surgery following just 1 year. Oops. And with that, I'll end.